Bismillah ar-Rahman ar-Rahim. Hello everybody. In this video I will speak about one important disease in the pulmonary medicine, which is sarcoidosis. We will start by epidemiology, etiology, and immunopathology. The definition of sarcoidosis. Sarcoidosis is a multi-system disorder of unknown cause, likely resulting from interplay of environmental and genetic factors. It's characterized by non-caseating granulomata and CD4 positive T helper 1 biased T cell response in affected organs. Commonly involves the respiratory system but can affect nearly all organs. And 50 to 60% of people have spontaneous remissions, and others may develop chronic and sometimes progressive disease. Regarding epidemiology, the incidence of sarcoidosis varies across population studies from 5 to 100 per 100,000 according to geographic distribution. It is common in African Americans, West Indians, and Irish, and it commonly presents between ages of 20 and 40. The etiology of sarcoidosis is the result of an abnormal immunological response to a benign environmental trigger or triggers or antigens, and the environmental trigger is likely to be a poorly degradable antigen but not a specific antigen or infectious agent. And the abnormal immunology occurs in a genetically predisposed host. Genetics of sarcoidosis. Familial and ethnic clustering of cases suggests a genetic predisposition. Best evidence of HALA association comes from large multi-center access study showing HALA DR B1 star 1101 is associated with susceptibility to disease in blacks and whites. Regarding immunopathology, unknown antigen triggers CD4 helper T cell activation and expansion. This response exaggerated and T helper 1 based with resultant interferon gamma and interleukin 2 production from these T cells. Activated T cells proliferate and release mediators, attracting additional inflammatory cells with concomitant macrophage activation and aggregation. And this leads to immune granuloma formation, which is enhanced by interferon gamma. And the granulomata themselves cause increased local fibroblast stimulation and hence eventual fibrosis. What are the differential diagnoses of granuloma on lung biopsy? Differential diagnosis of granuloma on lung biopsy includes sarcoidosis, tuberculosis, and Wagner granulomas, drug reactions, NTM, and fungal infections includes cryptococcosis, aspergillosis, coccidomycosis, and blastomycosis. The aspiration of foreign material, the primary biliary cirrhosis, and second-like reaction to malignancy. Now we will speak about the clinical features or clinical picture of sarcoidosis. More than 90% of patients with sarcoidosis have thoracic involvement with an abnormal chest X-ray, and pulmonary sarcoidosis can be an incidental chest X-ray finding in about 30% of patients, and there is spontaneous remission in two-thirds, and 10 to 30% have a chronic course. The clinical features of sarcoidosis include at least two distinct clinical courses. The first is Lovren syndrome, which is an acute disease and usually self-limiting, presents with fever, bilateral hilar lymphadenopathy, erythema nodosum, and arthralgia, and occurs particularly in Caucasian and has a good prognosis and resolves completely and spontaneously in about 80% within 1 to 2 years. A minority may develop lung disease. The second course is persistent or progressive infiltrative lung disease. Regarding hilar and mediastinal lymphadenopathy, sarcoidosis may be asymptomatic or cause cough or chest pain, and usually bilateral and symmetrical, and rarely unilateral and asymmetrical. This is what this would suggest alternative diagnosis more likely, and can associated with systemic symptoms of malaise and arthralgia, which are helped by non-steroidal anti-inflammatory drugs. And the course is benign. And in that context, we should say that it's important to exclude other causes of lymphadenopathy, such as tuberculosis and lymphoma. And we need CT and lymph node aspirate or biopsy. Usually does not require systemic steroid treatment. Stages of sarcoidosis. Stage 1, 85% resolve spontaneously over 2 years, and 50% develop lung infiltrates. The average time for bilateral hilar lymphadenopathy resolution is 8 months. Stage 0, we will find X-ray is normal. In stage 1, there is hilar lymphadenopathy only. In stage 2, hilar lymphadenopathy and parenchymal infiltrates. In stage 3, there is parenchymal infiltrate. In stage 4, there is fibrosis. Regarding seeing a patient with a possible sarcoidosis in a clinic, we may need to do HRCT plus or minus histology, and we should assess extent and severity and the presence of extrapulmonary involvement, and we should do chest x-ray, pulmonary function test, ECG, eyes examination, rash, renal function, serum, calcium, and liver function, immunoglobulins, and angiotensin converting enzyme. Stable or progressive by doing chest x-ray, pulmonary function, oximetry, or ACE, urea if renal involvement. Then we should treat the patient. Now we will go to diagnosis and monitoring. Diagnosis of sarcoidosis is based on a characteristic clinical picture plus histological evidence of non-caseating granuloma in any tissue, characteristic picture on imaging, including thoracic high-resolution CT or gallium scan, and lymphocytosis on bronchoalveolar lavage. Investigations. High-resolution CT is very important in diagnosis of sarcoidosis, and we can find micronodules in a subpleural and bronchovascular distribution, and fissural nodularity and bronchial distortion, irregular linear opacities, ground glass shadowing related to bronchovascular bundles, and nodular or ill-definite shadows. Air trapping due to small airway granuloma is common, and endobronchial disease in 55%. Minority has usual interstitial pneumonia pattern associated with worse prognosis, hilar and mediastinal lymphadenopathy, and CT-guided fine needle aspiration of subcarinal or mediastinal nodes may be possible and yield a tissue diagnosis. The other investigation is bronchoscopy. Bronchoscopy in sarcoidosis may include doing transbronchial biopsy or transbronchial needle aspiration or bronchial biopsy or BAL, but it may be not necessary if no diagnostic doubt, and may be important to exclude infectious agents, and positive yield of bronchial biopsy is 41 to 57%, higher if visible abnormal mucosa, and positive yield of TB transbronchial biopsy is 40 to 90%. BAL or bronchoalveolar lavage in sarcoidosis shows a CD4 to CD8 ratio of a number larger than 3.5, and the lymphocytosis more than 2 multiplied by 10 powered 5 cells per ml supports the diagnosis but is not diagnostic, and also seen in hypersensitivity pneumonitis and drug-induced uveitis. Mediastinoscopy for central or paratracheal nodes or open lung biopsy, 90% positive yield, may be necessary to exclude lymphoma, and surgical biopsy is not usually necessary, but if other procedures have not yielded a definitive diagnosis, it may be required. Lymph node plus or minus lung can be biopsied. Biopsy of other affected areas such as skin, liver, if indicated, as this may be easier to biopsy in order to make a diagnosis. And the Manto or Heave test is typically grade 0 in sarcoidosis, peripheral cutaneous injury to tuberculin due to migration of T cells to active sites of disease. Positive Manto or Heave test makes sarcoidosis a less likely diagnosis, although does not necessarily make TB more likely, and Heave testing not widely used now. Keyvine tests no longer performed clinically due to risks of transmissible disease, and it involves injecting homogenized splenic tissue from a patient with sarcoidosis to see if a granulomatous reaction occurred. After diagnosis of sarcoidosis, we will go to monitor of the disease or monitoring the disease. There is no single measurement. There is no single measurement to assess all the aspects of patients with sarcoidosis. Clinical examination and serial measurements are key. We can monitor sarcoidosis by doing the following: pulmonary function test, because pulmonary sarcoidosis gives a restrictive defect with decreased total lung capacity and vital capacity. Diffusion of carbon monoxide by the lung, or TLCO, provides the most sensitive measurement of change. Although many use a properly performed vital capacity as an alternative, and it's likely to improve with steroids, and pulmonary function test, in addition to restrictive defect, we can find also airflow obstruction. Chest X-ray may improve with time or treatment, and the high resolution CT in monitoring of sarcoidosis can help with determining burden of active disease, and ACE levels increase in up to 80% of patients with acute sarcoidosis, although can be normal in active disease. It may be a surrogate marker of a total granuloma burden. Levels become normal as disease resolves. Calcium. Calcium may rise with active sarcoidosis or in the summer months, and this may cause renal impairment, so urea or creatinine should also be checked. Bronchoalveolar lavage not performed routinely to assess progress of sarcoidosis, but reduction in lymphocytosis would indicate improvement. Because we said before that bronchoalveolar divergent sarcoidosis shows a CD4 to a CD8 ratio of a number larger than 3.5. PET scan may be positive in areas of disease activity, and it's not reliable for studying brain or heart. Also, gallium scan rarely used now as non-specific and expensive. Regarding management of sarcoidosis, most patients with pulmonary sarcoidosis don't require treatment. Asymptomatic chest X-ray infiltrates are usually just monitored, and the British Thoracic Society have recently issued guidelines which include the following. Because of the high rate of spontaneous remission, treatment is not indicated for asymptomatic stage 1 disease, and because of high rates of remission, treatment is not indicated in asymptomatic stage 2 or 3 disease with mildly abnormal lung function and stable disease. Oral corticosteroids are the first line of therapy in patients with progressive disease determined by radiology or on lung function and significant symptoms or extrapulmonary disease requiring treatment. Treatment with prednisolone or equivalent 0.5 mg per kg per day for 4 weeks, then reduced to a maintenance dose which will control symptoms and disease progression. Should be used for a period of 6 to 24 months. And biphosphonates should be used to minimize steroid induced osteoporosis. Inhaled corticosteroids, either as initial treatment or maintenance therapy, are not of significant benefit. They may be considered for symptom control, such as cough, in a subgroup of patients. Other immunosuppressive or anti-inflammatory treatments only have a limited role but should be considered in patients when corticosteroids are not controlling the disease or, or side effects are intolerable. At present, methotrexate is the treatment of choice, and lung transplantation should be considered in end-stage pulmonary sarcoidosis. Prognosis: there are no prognostic markers in sarcoidosis apart from good prognosis. Lofgren syndrome has complete resolution in 80% of people associated with HALA DQB1 star 0201. Poor prognosis with chronic disease, lupus perennial, nasal mucosa involvement, chronic uveitis, chronic hypercalcemia, and nephrocalcinosis, and neural involvement, and the age more than 40, and the black race. Regarding prognosis according to chest X-ray appearance, stage 2, 50% of cases recovers spontaneously in 2 years, and 30 to 40% require systemic steroids, and 10 to 15 required long-term steroids. Stage 3, worse prognosis, and only 30% show significant improvement with steroids. I will stop the video at this point, and I hope best wishes for all of you, and thanks. السلام عليكم ورحمة الله وبركاته.